Harvard in Boston. She's a leading internationally renowned expert in prostate cancer research and education. And likewise, we've got Chad Tang, and Chad rounds out our multidisciplinary faculty. He's a radiation oncologist, and he's focusing also in genitourinary oncology, and he's at the wonderful MD Anderson Cancer Center in Houston, Texas. So I'm privileged to be the moderator really here for these two outstanding colleagues. So we've already said hello and we've introduced and look forward to your questions. And here's our agenda. We've already gone through the welcome and the introductions. Treatment pathways and the latest clinical evidence. I mean, we really need to understand what's the pathway. There's no perfect pathway. There's guidelines, and there's still the joy of the art of medicine and individualizing patient care. And that's really, highlighted in this notion of personalized management. I mean, the one-size-fits-all, doesn't really cut it anymore. Patients demand more, as they should, shared decision-making, and us being able to say, what are all of my options, not just to the patient, but to their caregivers and their supporters. We'll finish up with some key take-home messages, a lot of opportunity for Q&A, and we'll get you out of here on time. So where in the treatment journey of patients with metastatic castration-resistant prostate cancer do you consider the use of radiopharmaceuticals? We're going to get into a lot of data in a minute, but I want you to just sort of ponder that notion right now. Are you actively embracing radiopharmaceuticals? Do you want to and need to learn more? Are you sort of, are you dabbling in it? Are you trying to figure out what your processes are for appropriate implementation, not just from a multidisciplinary specialty concept, but do you have the right facilities, and do you have the right equipment? Do you have the right safeguards? These are really all the things, in addition to all the many other novel mechanism of action class of drugs that have already received approval, and Dr. Tang is going to go over those in a minute. So, treatment pathways and the latest clinical evidence. So how confident are you, our first question, are you right now in collaborating with the multidisciplinary team? And you can define that however you think multidisciplinary registers with you. And to me, that wheel of multidisciplinary just keeps getting larger and larger. Our nurses, advanced practice providers, pathologists, physical therapists, pharmacists. So the answer here is not confident, slightly confident. Of course, med-onc, rad-onc, nuke med, uros, primary care physicians. Slightly, moderately, mostly very confident. All right, so we've got, it's pretty spread across the board. I mean, moderate to mostly to very, we're looking at more than, a little over 50%. But there's still, I think, the opportunity to recognize, how could we be doing things better? So I appreciate that. And, for when, doing programs like this and being with Drs. Tang and Morgan, I always learn. I always learn at ASCO GU. And all of these really great meetings that we have thanks to these organizers. And the ability to learn, hopefully tonight, take something home with you and so that you can really optimize your patient care. So with that, let me hand it over to Dr. Tang.
All right, great. Thank you, Neil, so much. And thank you all for joining. So this is just a short list of FDA-approved therapies in metastatic castration-resistant prostate cancer. A lot of great options out there. Obviously, ARPs, taxane chemotherapy, but radiopharmaceuticals are what we're going to focus on in this talk. And there's going to be two that we're going to spend most of our time discussing, which is radium-223, which has the FDA indication of symptomatic bone mets with no visceral metastases, and lutetium-177 PSMA-617, which is used for PSMA-positive metastatic disease, prior treatment with ARPs and taxane, or patients who can't get taxane. and this is based on the vision of PSMA force. So we'll be discussing these two main drugs, radioligands, and in the context of metastatic CRPC. So when thinking about radioligands, one of the most important part is the radioactive part. And there are a number of different components of this. There is the linear energy transfer, and that basically is how much energy is distributed by that molecule. And then there is the distance that that molecule can penetrate. So we have three main classes of energy emission here. Beta particles, which are probably the one that we probably know most about because we have lutetium-177, which is a beta particle emitter. Beta particles have low LET, 0.2 keVs per micrometer. But however, they penetrate very far. The distances can penetrate several cells. Alpha particles is another very interesting, very exciting emerging area where you have much higher LET. These are, as we know, 2 protons, 2 neutrons, much, much heavier than a photon. So they're able to cause double-strand breaks. And then you also have Auger electron therapy. And what this is a different electron, which is in between the big bowling ball of alpha particle and heavier than the beta particle. But it also has a little bit less distance that it can penetrate. And from this class, I think terbium is going to be a very interesting molecule that's ready in the phase 1 setting. And also in alpha particles, we of course know actinium in addition to radium and others. So talking about this a little bit more, the two drugs that we're going to talk about, two radioligands that we're going to talk about are radium-223 and lutetium-177 PSA for the most part. As discussed earlier, radium-223 is part of that periodic table that is very similar to calcium. So it ends up intercalating into the bone matrix and releasing the alpha particle. As discussed earlier, this is a high LET particle because it is heavy. It has 2 protons to 2 neutrons, so it's able to directly get into the nuclei of these cells and cause double-strand breaks, which are very lethal to most cells. On the other hand, lutetium-177 PSMA, it is a low-energy emitter because it emits a photon, and that photon causes a lot of more single-strand DNA breaks. Now, usually one single-strand DNA break is not enough to kill a cancer cells, but when you have more single-strand breaks, that's enough usually to overcome the repair mechanisms. And as we know here, for lutetium-177 PSMA, it is compounded and it is bound to a small molecule that binds onto PSMA. So the first trial that we want to discuss is the Alsimca trial, which really brought this class of drugs to the forefront in prostate cancer. This is the phase 3 trial in patients with confirmed symptomatic CRPC with at least 2 bone metastases who had at least docetaxel or were found to be docetaxel unsuitable. And the randomization is very simple, radium-223 plus best standard of care versus placebo. The primary endpoint in this trial was overall survival. So what we saw and what led to the FDA indication for radium is an OS benefit with a very promising hazard ratio of 0.7. This was, of course, significant. And also, very importantly, because it percolates in the bone matrix, it reduces the chance of having a metastatic disease in the bone causing a symptomatic skeletal event. So that also was favorable towards radium-223. There's less symptomatic skeletal events. Generally, radium is well tolerated. Here is the toxicity profiles. On Alsimca, there wasn't a big signal that emerged suggesting worse outcomes with the radium. Now, the next study that moved radium a little bit earlier is the ERA-223 study. And this study moved radium into the metastatic CRPC space with bone metastasis once again, but in patients who did not receive docetaxel. And patients here received radium with abiraterone versus abiraterone. And the primary endpoint here was symptomatic skeletal event-free survival. And what this showed was for both the primary endpoint and the key secondary endpoint of overall survival, there was no difference in outcomes. one of the most important things that we learned from this study, the ARA-223 study, was that when you combine these two molecules in this patient population, there was a lot more fractures. You can see here any grade 17% compared to placebo, which is 6%, which raised a very interesting safety signal in these patients. And this was capitalized on this most recent study. So in Peace 3, this was a cooperative group study run in Europe. It took 446 patients, very similar population to the previous ARA-223 study, patients who were CRPC, who had not received docetaxel earlier, and it randomized them now to radium plus Enza versus Enza, with the primary endpoint of radiographic progression-free survival. Now, because of the very interesting safety signals that we saw in ARA-223, they made, after the first 119 patients, mandatory use of bone-protecting agents. And it was a key consideration that really helped propel these results. So let's hear from you. What was the effect of radium-223 plus enzalutamide versus enzalutamide alone in Peace 3? Number one, significant improvement in radiographic progression-free survival and overall survival. Number two, significant improvement in radiographic progression-free survival, but not overall survival. Number three, significant improvement in overall survival, but not radiographic progression-free survival. No difference between the two arms. We tabulate.
So I have a trivia question while you're all answering this. One of the three of us up here, you have a 1 out of 3 chance. One of the three of us here gave the first dose of radium-223 in the United States post-FDA approval. Who was it?
It was not me.
Yeah.
Thank you. Thank you. I actually beat out Oliver Sarter by like a day.
Oh, really?
Oh, yeah. I was very happy to.
No competitive spirit here.
No competitive.
Yeah. Okay, great. So as can be expected, about 50% of the patients said significant improvement in radiographic PFS and OS. And we're going to go over that in a little bit. Minority said improvement OS, but no radiographic PFS benefit. Let's see. So these were the results presented at ESMO, and they did show that the radiographic PFS has a hazard ratio of 0.69, and which was significant, and the overall survival has a hazard ratio of also 0.69. So easy to remember that. Both significant. And as we just learned this morning, the final overall survival confirmed once again a significant hazard ratio of 0.76, significantly in favor of adding radium to enzalutamide. Now, with the use of the bone-protecting agent, after the first 119 patients, they did not see here, unlike ARA-223, a concerning signal for fractures. So once again, we saw that radium-223 was very well tolerated. And it should be noted that a lot of people almost think of this as a triplet, because you have to do Enza, the radium, and the bone-protecting agent together for us to get the benefits that we're seeing.
You know, I've seen Bertrand Tombal and Silke Gillison present this. If you just look at the control arm that didn't have radium, just had Enza, there was the same benefit as well by adding the bone protective agent. That was a really key piece of information, too, about the importance of bone protective agent.
Yeah, something we often overlook, so it's a great point. All right, so now take it away.
Great, thank you. So let's talk a little bit about the VISION trial. This is actually at this point not one of the newest trials, but was, I think, really exciting as it was coming out and certainly has changed our landscape. This study looked at patients or included patients who were relatively heavily pretreated. All of the patients had had a prior AR pathway inhibitor, and all of them had had prior taxane. They could have had multiple taxanes, however. They could have had multiple AR pathway inhibitors. They underwent screening with a PSMA PET scan, and they had to have disease that was identifiable on that PET scan to be eligible. Unlike the therapy trial, which we know is also occurring sort of around the same time in Australia and New Zealand, we only used a PSMA PET and then standard conventional imaging like CT scans to have patients enter this trial. Whereas in therapy, they used both an FDG PET and a PSMA PET. So that style of selecting patients has not really been adopted in the US, though is something that they're still often using in Australia and New Zealand. It's just something I always point out as we're thinking this through. So PSMA PET positive disease, uptake greater than liver. As we can see here, these patients were randomized 2-to-1 to receive the lutetium-177 PSMA 617 small molecule targeting PSMA protein on the cell surface with best standard of care. And in many cases, this was going to be an alternate AR pathway inhibitor to the one that the patients had received in that earlier line. But it wasn't always. In some patients, it was a bone protective agent or a steroid or whatever the standard of care was for this patient population. And as I said, some of these patients were so heavily pretreated that really they would get a pain medicine or a bone protective agent, and this was the best standard of care. This was randomized against the best standard of care. Importantly, when we do talk about that treatment arm and the control arm, there were some limitations on what we could call best standard of care. We didn't have safety data combining lutetium-177 PSMA 617 with cabazitaxel as an example, or with radium. So although these were allowed prior to inclusion in the trial, they were not included in that standard of care arm because standard of care had to be combined with lutetium-177 PSMA 617 in a combination treatment. So patients were followed at that time for both PFS and OS. You can see that all the stratification factors, and they were followed with standard conventional imaging to monitor for progression. And here we can see the imaging-based progression-free survival clearly favoring the lutetium-177 PSMA 617, median rPFS 8.7 versus 3.4 months with the two groups here with a hazard ratio of 0.4. We do have a concomitant OS survival endpoint as well in this co-primary endpoint. And we can see again, lutetium-177 PSMA 617 clearly beating the standard of care. And the hazard ratio here is 0.62, highly statistically significant, about a 4-month difference between the groups. When it comes to safety, I think there was a lot of interest in whether this would cause cytopenias, things like that, and there were some cytopenias, but in general, I think there was nothing unexpected when we were exposing patients to radioactive radioligand therapy. There were some, as I said, cytopenias, fatigue as well, some dry mouth, because there is some PSMA expression on the salivary glands. But even with extended follow-up, there were no additional safety signals, and all of these side effects were to be expected with the agent being used. Of course, when we have something that we know is successful in a heavily pretreated population, we want to understand if we can move it earlier. And studies for many, many years in prostate cancer and in other cancers show that when we use something earlier, when disease burden is less, when disease heterogeneity is less, we're probably going to have a bigger effect. So this led to the design of the PSMA-4 trial. Also important, I think, because the VISION trial, of course, is a post-chemotherapy population. And in many of our practices, we have patients who are not able to get chemotherapy, don't want to get chemotherapy, and we do need to have options for everyone in order to, again, try to personalize our care. So this study included patients with metastatic castration-resistant prostate cancer who have had at least one AR pathway inhibitor here. They again had to have PSMA PET positive disease. They were taxane naive unless they had it in the neoadjuvant or adjuvant setting at least a year before. Couldn't get a PARP inhibitor because they were not going to be eligible for a PARP inhibitor. They were randomized 1-to-1 to lutetium-177 PSMA 617 versus the ARPI switch. So if they'd had abiraterone, they were going to get enzalutamide or vice versa. I would say very, very importantly, around this time, we were experiencing a fair amount of evidence that suggested that an ARPI switch was going to be a suboptimal control. And so very importantly, the investigators built into this study crossover that allowed those patients who were getting an ARPI to then get treatment with lutetium-177, PSMA-617, and they were unable to get this treatment in any other setting. So this gave a patient, one way or another, an option to get this drug, which many had just seen actually be quite positive within the VISION study. So that's an important part of the design, I think, especially as we're thinking about this ARPI change as maybe not being the ideal. Over time, it will not be considered an ideal control arm for future study design. These patients were followed for rPFS by central imaging review, and as I have said, there's the crossover, and so also, of course, following for overall survival. So let's hear from you. Take a minute, sign back into the system if you have gotten out of it, and let's talk. What was the effect of lutetium-177, PSMA-617 versus that ARPI switch in PSMA-4? Was there a significantly improved PFS and OS, a significant improvement in PFS but no OS benefit, a significantly improved OS but no PFS benefit, or no difference between the two arms? Tell us what you think. Catchy music here. All right. So it looks like almost 2/3 said significantly improved PFS and OS, and then just under that, improved PFS but no OS benefit. Let's take a look at the data. All right. So here's the PFS data. There's a PFS benefit. I think we can all agree on that. Clearly favoring lutetium PSMA-617. Hazard ratio here is 0.49. We've got 11.6 months versus approximately 6 months, demonstrating that difference. When it comes to OS, though, remember there was a substantial amount of crossover, a key and critical part of the trial design. There is no statistically significant benefit in terms of overall survival here. Hazard ratio is 0.98, so still less than 1. But this does not meet statistical significance, and I think that as we look at this overlapping curve scenario, we can tell. So whether you give it early, whether you give it later, it seems to be helpful, is important. Not harmful, also important. When it comes to the safety signals, there's no new safety signal here. Still have some dry mouth and some cytopenias, but these seem to be well tolerated for patients. So moving on, as I said, everything that we do in a later later area of the disease, we want to try to move forward as is possible, if that is helpful for patients. And PSMA addition is the newest kid on the block, and we heard some data about this today. This included patients who had newly diagnosed metastatic hormone-sensitive prostate cancer. And I apologize, I'm not using the new ARPN, whatever. I'm practicing, so I'll get to that soon. Old-fashioned hormone-sensitive prostate cancer, new letters. All right, so these patients were enrolled. They had to have PSMA PET-positive disease as well. And they had to be able to get ADT and an AR pathway inhibitor as their primary treatment. So a doublet backbone, there's no chemotherapy in this trial design. Patients were randomized 1-to-1 to receive lutetium-177, PSMA-617, plus ADT and an AR pathway inhibitor, standard of care, versus ADT and an AR pathway inhibitor, standard of care. Patients were followed for rPFS. They could have crossover allowed and safety and OS follow-up ongoing. You could see there were some stratification factors, including by these charted criteria of high versus low volume and their age, as well as some other things here, including primary radiation of the prostate or prostatectomy, and then your follow-up periods. So here's the radiographic progression-free survival. As we can see, this does favor lutetium-177, PSMA-617, so this did meet its primary endpoint of radiographic progression-free survival benefit with a hazard ratio of 0.72, and this was statistically significant. And the median rPFS is actually not reached by these arms here. In terms of overall survival, this is an interim analysis. We can see that the hazard ratio is 0.84, so the point estimate is less than 1. Again, reassuring us there's no clear evidence that we're causing harm to these patients. But we do have to look at the confidence intervals, which do extend over 1. So we'll continue to see this data mature. As more events happen, we'll see how the curves go. But this is, I think, quite promising. We look at the safety signals here. Again, very similar. There's no new safety signals coming out of this trial. So we have 3 studies now. We saw the quality of life data today too. And I just want to say, for those who were not in this session, it was a wonderful reset, because I think that the way that the data was presented previously, it suggested almost that the patients who were receiving lutetium-177 PSMA-617 had a poor quality of life throughout the entire study. And what was clarified today is that, yes, when you add something else onto a backbone of something and then compare it to the backbone, you will probably have additional side effects during treatment, but after treatment, you can actually have stabilization and actually similar quality of life between the groups, which was what was shown. So I think this is an important caveat that was pulled out nicely today in the presentation. So for those of you who weren't able to see it, Michael Morris presented. It's a very nice, rapid oral presentation from today. So moving along to one of our other agents here, we have actinium-225 PSMA. This is the Warmth Act retrospective study. So this was looking at use of actinium, PSMA-targeted actinium agent every 8 weeks as an alpha targeting or an alpha particle agent, as we heard, in patients with metastatic castration-resistant prostate cancer who were receiving their treatment in sites including Australia, India, Germany, and South Africa. The most common AE here is xerostomia. So again, PSMA expressed on the salivary glands, and when you hit that with an alpha particle, you can have a more profound effect on and cause dry mouth a little bit more than a beta particle, because we heard about that high energy. But here we can see the median PFS 7.9 months and a median OS of 15.5 months. And this is the change of baseline PSA, showing a nice decrease in PSA for a large portion of these patients with a reasonable safety profile, but noticeable xerostomia. There are many ongoing trials with radiopharmaceuticals. We have heard results from the LUNAR trial. We have heard results from Alphabet, Comrade. Many of these are combinations of these different radioligand therapies and other agents, including PARP inhibitors. We can see Alphabet, which I think is a really clever title. It's a radium and lutetium-177 PSMA INT, so an alpha and a beta particle, just really cute. The Violet trial is looking at terbium, which again we heard is this really interesting particle. So lots of things happening that I think we're going to be on the lookout for. And there are many ongoing phase 2 and 3 trials with additional radiopharmaceuticals. I have to say, these tables are overwhelming almost, but we had so many trials that we kept naming that Medscape was very kind to put them all on tables for us, but that's why you're looking at this, because we're excited about so many of these. And where do we actually find radiopharmaceuticals in the guidelines? They are incorporated in multiple areas. So if you're talking about pre-AR pathway inhibitors, you have patients with bone metastases, asymptomatic, mildly symptomatic. These are your patients for radium and enzalutamide. I had a patient that I could put on this last week. This patient didn't want to intensify with an ARPI until he was sure that his PSA did not get below a certain threshold. And within 6 months, he's actually starting to have mCRPC. So I was like, oh my gosh, I almost never have a patient who's never had ARPI in the hormone-sensitive metastatic setting. We're going to use Piece 3. So this is the setting where we think about this, if you have patients progressing on ADT alone. And then, as we can see, post-ARPI, pre-docetaxel, post-ARPI, post-docetaxel, we do have lutetium-177 PSMA-617 in both of those settings when we have PSMA-positive metastases. You've got to use the scans to find the biomarker. And then we also have those patients who have symptomatic bone disease, which I have typically defined as people having fatigue or bone pain. It doesn't necessarily need to be bone pain alone from my perspective. These patients can receive radium-223 if they have bone-predominant disease and no large lymph nodes and no visceral disease, because the radium obviously is not going to be hitting that disease. And so I'll pass back to Neil to lead our panel discussion.
Yeah, no, very good. So I think what you heard, in a fairly rapid presentation, because there's just so much data out there, and we didn't even so many early phase, first in human data trials that are being developed with alpha and beta particles, and looking at dose optimization and escalation. So it's a really exciting time. Those really busy trial landscape slides are there to inform you that this is here. and why I think we're proud to do this presentation. So part of it is not only new molecules and different schedules, but how do we combine potentially? Because we're always thinking, is that another way to get a reasonable of bang for your buck, as you were saying? Maybe there's a little bit more added toxicity, but maybe there's an optimization of clinical benefit, and then the quality of life and the toxicity profile can also be managed. As it relates right now to 2 approved therapies, radium-223 and lutetium-617, where do you sequence these patients? And our cases are going to sort of ask you for your thoughts on that, and I'll ask the panel as well. We talked about the importance of bone health agents affecting outcomes and the crossing of survival curves. One of the things, Alicia, that you talked about in both in Vision and in 4 was the crossover. And the fact that at least, a lot of times in some of our studies, we've had the sequencing of ARPIs. But I'm curious, and Chad, you as well, the market data is, despite the fact that it's considered mostly a, quote, lateral move to go from one ARPI to another, or an androgen biosynthesis inhibitor as with abiraterone, maybe you get a little bit better effect with an ARPI. But yet the market data suggests so many of our colleagues, medical oncologists, uro-oncologists, they do that still. And so I know, your comment was well stated as to, at the time, that's why this was performed. And many patients will just refuse to get a taxane. But do you have thoughts about that, that we still see a lot of that ARPI sequencing?
We do, and it's interesting because at least the data I've seen, maybe 15% response rate, Enza after Abi, no real response Abi after Enza, at least in the few studies that I've seen. There's a nice crossover study from Kimchi and his group in Vancouver that looked at this. But today, actually, I think it was Evan maybe giving the talk, Evan Yu, he quoted somewhere like 30% of a response rate. So I think that our relationship with this particular strategy of ARPI to ARPI continues to evolve. It is not generally what I seek to do, but I think that there are opportunities where it may be the thing that is right for the patient. And ultimately, I only bring it up because I have been in discussions, as I think you've been too, where people have said, well, that control arm is completely invalid. That is an unethical control arm and should not have been the case. And in the context of the current clinical practice, the past clinical practice, the reality of the situation, that control arm was completely appropriate, particularly because the investigators specifically built crossover in to allow every patient on that trial to have access to something that they would not have access to otherwise. So that's why I bring it up. And it is something that I think at some level it will continue to happen. And I was actually speaking with colleagues earlier this morning. I was talking about giving Sipuleucel-T in a relatively slowly progressing patient, no visceral disease, and it was appropriate. And often, and I learned this from you probably a decade ago, I often use an alternate AR pathway inhibitor in combination with my CYP-T because I think that may perhaps help the patient, gives them a maintenance after they finish their CYP-T, and may also blunt some of the PSA rise. It seems to work for some patients. Anyway, there are all of us, even I who stand up here constantly and say, do not sequence your ARPIs. There are situations where I do it.
Yeah. No, absolutely. Chad? Thought?
Yeah, and I think you bring up a great point, Neil, about patients really not wanting to go into chemotherapy.
Yeah.
And there are some patients who are older and they just say, let's give it a try. We'll see what happens. And I totally respect that. So I think that patient preference plays a big role in giving these switches.
Yeah, let me, it's not on here as one of the thought bubbles, but one thing that comes up a lot is the differences in the authorized users for radiopharmaceuticals. And, where do you see that? It's different in different academic community, different parts of the world. What's your take on, the radiation oncology, nuke med radiology? Yeah. Even there's some medical oncologists that actually clinical oncologists, for example, in the UK, they do oncology and they do radiation pharmacy.
Yeah. So my understanding is based on our training pathway, in the US at least, there's only 2 specialists who can become authorized users. Those are radiologists, nuclear medicine doctors, and radiation oncologists, because it's built into a residency. However, one could, in theory, get additional training and then apply to become an authorized user. But to your point of who's doing it, I think it's a lot of history and tradition. Who has a big part of this is having the right technicians who know how to safely administer, safely use the Geiger counter afterwards, and counsel patients afterwards, and then also just having some of those facilities in place to hot lab and everything to be able to take care of the radioactive byproducts and patient products sometimes. So I think it's who has evolved into this space a little bit. Many times it's a nuclear medicine doctor. In other places, a radiation oncologist. So a little history is involved.
Yeah, that's a great summary of it. The bone health agents, great data from Piece 3. Clearly, we didn't have time to get into it, but the importance of some vitamin D and calcium supplementation, and then, of course, exercise. Because it's just the natural, devolution of muscle mass and inanition and sedentary lifestyle associated with T suppression. So those things all contribute, and doing those counterintuitive, the things that prevent that, along with a bone health agent, an anti-resorptive, whether it's a bisphosphonate or a rank ligand monoclonal antibody, really helps those patients. All right, so let's talk about the personalized management of mCRPC. And I think that, to me, that's really where we are today, not only in mCRPC, but, clearly in sensitive biology as well. We don't have time to get into all that. Alicia touched on it with the addition trial, which I think was a really fascinating study. And we'll see, if that gets a regulatory approval. But the precision and how we do testing, we're not getting into a whole bunch of testing, but we all know the importance of next generation sequencing, and the importance of looking at both germline and somatic, because we have personalized management approaches. So we got a couple of cases for you here. Here's our first one. This is a 67-year-old male. He has no eyes or nose. He just has facial hair. That's probably some sort of a congenital syndrome. I don't know. I mean, that's probably the answer. But
yeah. The medical oncologists would definitely send him to the ER.
Yeah. They're like, sorry, sir, you don't have any. Okay. All right. So he presents with low-volume prostate cancer with bone metastases, and low volume, right? I mean, now with that's interesting. We had the classic charted definition based on conventional imaging, and that's clearly now with PCWG4, which everybody should download and read. And Andy Armstrong gave a great presentation, a lot to really review with that. But so this patient just gets nearly 2 years of androgen deprivation therapy for presumed low-volume MHSBC with bone metastases, so no visceral metastases, no obvious lymph nodes. And he progresses, and then, time goes by, new modalities, and now he gets a PSMA scan. And just on the PSMA scan, you're told he's got 5 lesions, axial and appendicular. So. And now he has, nothing's lighting up, no PSMA avid areas in the lung or liver or brain, and no obvious lymph node avidity, and he's asymptomatic. So mCRPC, PSA is rising. He's got, PSMA only bone lesions. So, and we see patients like this, right? People come to your clinic, wherever you are in the world. So what is your choice of treatment for this patient? A monotherapy ARPI, radium-223, radium and enzalutamide, docetaxel, cabazitaxel, lutetium-617. It's kind of like a new Brownian motion that's not brown. It's okay. All right. So look what we have here. Oh, all right. All right. You were listening to Dr. Tang's presentation. So the majority clearly went with the combination based on the PEACE-3 results, OS, PFS benefit, radium, and ENZA. One could clearly, it could go with a monotherapy ARPI. I hadn't seen one yet. Interesting, and I'd love for you to comment on this one, the radium alone versus the radium ENZA, especially given the Alsimca data of 4 or more bone lesions really that had benefit. But it's interesting. Docetaxel, cabazitaxel. Well, the indication is you have to progress on docetaxel, and also lutetium. So maybe Chad, you first on the combo versus radium alone or ARPI alone, and then Alicia, maybe you comment on going right to lutetium.
Sure. So I think, as we all know, PEACE-3, as we presented, is what's driving the radium plus enzalutamide, and that's pretty level 1 evidence to suggest that. So that makes a lot of sense. In terms of a monotherapy, I guess it's plausible. You could get a little bit of mileage off that, but I think it's maybe not quite level 1 evidence level. And I just wanted to point out one other thing, using my external beam hat, is that with only 5 mets, he's oligoprogression. So something that's not on the list, you could do radiation to all sites in theory, and then try to keep them on Lupron for a little bit longer as well. Not level 1 evidence by any stretch, but something that sometimes we can eke a little bit of time out as well.
But I appreciate you said that, because this is one of those cases where I just see this going on a lot in the real world without the level 1 evidence.
Yep.
And sometimes things will just start to get adapted based upon that type of real world evidence. It's kind of fascinating.
Mm-hmm.
Yeah. Alicia?
Agreed. So, I do think radium is, as a single agent, a little bit of a stretch if there's an asymptomatic patient, and why not just add on the enzalutamide? I think that makes complete sense. And the challenge with lutetium PSMA-617 is that the patient hasn't been exposed to an ARPI. So there's really not an indication to give that medication yet. And so this would not really be what we would do in this situation.
Yeah, no, exactly. But we're starting to get this proverbial, embarrassment of riches now, and all these things. And we'll get to what if they had an HRR alteration or some other genetic alteration that was informative. What we have up here right now, and you and I have done a lot of this, Chad. You may have also, but we always have phrases and acronyms. But the notion of shared decision making, and you and I we've got a paper we're trying to get published, and maybe Alicia, tell us what when someone says to you, kind of concisely, what does shared decision making really mean?
Yeah. So I think of it as this sort of bidirectional communication between the doctor trying to communicate, here are your options, and this is most commonly the conversation that you have when all the options essentially convey or confer a relatively similar benefit in terms of cancer control. This is not, shared decision making happens in all settings, but it's easiest, I think, when all of the options kind of give you a similar cancer control. And in this case, we have very similar OS benefit, remembering that none of the trials are going to be head-to-head comparisons of this treatment versus that treatment. But if we look at some of the early data from docetaxel, Sipuleucel-T, even Vision, we're getting about chemotherapy. These are somewhere between 2.5 and 4.5 months of survival benefit, in addition to whatever one would have in the mCRPC setting. So they're actually quite similar. This is really kind of the perfect situation
for shared decision making? And I know you said one sentence, so I'm wrapping it up. But it's the doctor communicating kind of this information and what are the side effects and what does it look like to live with this therapy or that therapy. And you please tell me, what are your personal needs, your personal preferences, beliefs? Can you not get to the clinic every so often because you have to take somebody to daycare? Can you not get a radioligand therapy that's a beta emitter because you have your granddaughter living with you after school every day, however long? Or maybe you can because she's going to go to an after-school program and her parents are going to pick her up. So what are your needs and who do you take care of at home and who takes care of you and all of these kinds of things so that you can make sure that the treatment is something that's invested in by both the patient and the doctor. And I think it leads to better adherence, and ultimately if we can do that and people believe in what they're doing, I think outcomes are better.
Chad, thoughts on shared decision-making and how it's changed, if at all, for you?
Yeah, so I think Alicia brings up great points. I think it's a two-step process, an establishment of goals mutually that you learn about from the patient and their lifestyle and what they value, and then a discussion of how the treatments kind of fit into that goal. I think the way that things have changed a lot is Dr. Google and Dr. AI Google has stepped in the scene, and sometimes a third opinion in the room with as we know from influencers and stuff, talking about different things. So it's a lot more noise in the atmosphere these days to make this shared decision making. But I think fundamentally it's the same still.
Yeah. So I take 100% agree, but I take a little bit of a different thought process on this, and I think to myself, given like the arc of my career, and I think back to my training, and this sort of classic, look at these, cartoon characters up here, but you see it on television, right? The classic, gray-haired, guy or woman gets in there with the long white coat, got doctor, big letters, MD on it, and goes in and very paternalistically says, here's what you have, this is what you need to do now. It's a very paternalistic way of having conversation. And what I love about shared decision-making is it puts the burden on us as the physicians to say, it's gotten complicated, but I need to explain to you what all of your choices are so that you can make as thoughtful of a decision as possible. And that, I have to do a better job of explaining. I can't just walk in and walk out and tell you this is what it is. You and your supporters, your caregivers, you need to make the decision alongside me explaining it really well to you. And I think that it's a change in how we are educating medical students, residents, fellows, and ourselves. Because that's really the burden. And understanding, I think you both alluded to it, is the patient, of course, with all their comorbidities and their drug list and their how risk averse or how risk tolerant are they?
Yeah. I totally agree with you. I think one of the most interesting parts of shared decision making is when we sort of help people walk through their beliefs and preferences. We help them walk through the questions that we ask, that we also try to kind of get at some of these obligations with different treatments and their wishes to have this outcome or that outcome. We help them get to that decision in a very active way, I think, by inserting our knowledge along the way, but also really eliciting what's important to them, what their goals are and what their needs are.
Yeah. It's not easy, right? Because here we are, we're all spending our time away from our practice and our families, and we're learning, and we're getting all this great new data. And then you have somebody who comes in and says, well, but can I get ivermectin?
No.
I mean, this is sort of like the bane of what
you use that all the time.
Yeah, right. Well, and that's getting trusted sources to rely upon. So, okay. So if the patient was started on ARPI monotherapy, or radium and an ARPI, or docetaxel, would you select a bone health agent? Only if the patient had bone pain, only if the patient was not taking adequate vitamin D and calcium supplementation. Yes, in all cases, for this is not required. Okay, well, pretty much everybody, got it right here. I just think this is particularly important for our mCRPC patients, And again, it's not just with radiopharmaceuticals. It's with taxane-based therapy and ARPIs. It's with PARP inhibitors as well. So it's great that most of us got that one right. Okay, next question. Yeah, the MDT, bone health agents, at least now there's a lot of biosimilars coming into the market. At least in the US, they're becoming less expensive. But just a quick, I know we've got a few more things to go through, but I just love to hear how your impressions of the MDT have, from both of your standpoints, how's that evolved over time? Where do you think that's going?
Let's start.
No, please.
Okay. Well, I think now the MDT has gone bigger. Nuclear medicine has kind of entered the fold a little bit. And I think the data has evolved so that local therapies as well have kind of also entered the fold a little bit more. Treatment of the primary or METs into the MDT discussion. So MDT used to be a little bit lonely, I think, for metastatic CRPC or metastatic even HSPC. But there's a lot more people involved, a lot more interesting data, some anecdotal, some less so, that kind of influence it. So I think it's a growing area. Everybody has a little bit to offer, I think.
Yeah, I also appreciate the pharmacist because especially as I'm starting new medications, I'm always asking, her name is Bailey, she's lovely, and asking her for help and is there a way, should I dose adjust this? Should I talk to the cardiologist and see if they can change that or this? I think that's wonderful. My nurse navigators are talking to patients about, I know she told you the side effects, but let me tell you the real story. Here's the rest of the information that she missed. And I think then my PA and my nurse practitioners also constantly there to support. Obviously, I'm here. I'm not supporting my patients at home. My NP, my PA are taking care of all of the questions that come up when people have questions, about their care and seeing my colleagues in clinic who many days I feel like I'm the one supporting them. That's the way it goes. But the MDT is filled with people that are doing all of this work each day that, some of them are doctors, but there are also all these others as well.
It's a great point. And I also love the fact that, tumor board and the ability to do virtual tumor boards and have all these people on speed texting so that are just some kind of little, tricks and pearls to, really enhance that MDT experience. Okay, last case, 63-year-old male. He presents with de novo metastatic hormone-sensitive prostate cancer. He has started on doublet therapy with degarelix and apalutamide, and then he presents with progression. He has a PSMA scanning, and he has lesions that light up, PSMA avid, in the kidney and the liver. His molecular testing is performed, and he's negative for HRR alterations and microsatellite instability. But we'll get back to that.
He also doesn't have eyes or a nose.
He also, it's a series of cousins in the same town. They're all.
It's an epidemic.
That's right. Okay. So what is your choice of treatment for this patient? ARPI switch, change the APA to another ARPI. Now go with radium for his kidney and liver avidity, docetaxel, lutetium-617, or PARP inhibitor. Okay. Yeah, interesting. And I think in all these questions, we're like, APCCC, everything's accessible to you. Yeah, I mean, I'm not I don't believe in the switch. Doesn't have bone lesions for radium-223. DOSI is certainly potentially appropriate. Lutetium, yeah. A PARP inhibitor, even though he didn't have any alterations.
It was confusing on that.
It was a little confusing.
It was confusing.
Yeah. I do. Yeah, I agree. I thought about changing that. Okay.
Can I just add one thing in that? It's interesting at a kidney lesion.
Right.
Yeah, that is unusual.
And we have seen clear cell renal cell carcinoma be our PSMA avid. So he may need additional workup for that kidney lesion.
Maybe a biopsy of that lesion.
Thank goodness for the MDT tumor board. That's very, very helpful.
All right, and then the kicker in is, what if the patient had an HR positive tumor? Then I think the PARP inhibitor would certainly been a reasonable issue or consideration. All right, let's kind of keep going along here. And this is important, I'd love to get some feedback. Oh, we got some good questions popping up over here too. Okay, what major barriers do you see for using radiopharmaceuticals? I'm unfamiliar with supporting data, cost, access, meaning not cost so much, but just the implementation, the supporting structure. Inadequate infrastructure, shielding, disposal of the waste, no available pathway for referral. Access could be approval, but we sort of assumed that. Okay. Yeah, I mean, economics is always an issue. You have to have accessibility, the infrastructure. I think this is really important. It's, Chad mentioned the importance of having an authorized user. Chad, would you like to maybe go into some of the things that you're familiar with regarding shielding and disposal?
Yeah, so one thing a lot of people do perseverate on is having a bathroom for the patient. So you do need at least 2 bathrooms in the clinic that you're using, because you can contaminate a bathroom, and if you only have 1 bathroom, then you're kind of sunk. You do need to have people who are technicians who know what they're doing in terms of handling this compound, dispose of the compound, and have the adequate ability to shielding the Geiger counters, be able to survey afterwards the bathroom and the rooms afterwards. And then most importantly, also, you do need to educate the patients correctly about what to do after they get their radioligand therapy. And they're all different sometimes a little bit too, exactly what you're doing. So there's a lot of things to be kind of put in place before you can start giving these.
Yeah, you have to know some of your local regulations, but I think the answer is these are all surmountable.
Yes.
Yeah.
And we want to make sure we have all these things available for our patients. There's nothing worse than, I think, not being able to offer something to a patient and they go to another part of your state or your country, and somebody offers something, and then they come back and they said, well, you didn't offer this to me. It's a little bit.
It's hard. But, one thing that I think is getting better, but is a real barrier, is access, the geographic barriers. I have patients who come down to Boston from northern Maine, which is surprisingly large. You could be almost in Canada much faster than coming all the way down to Boston. It's 6 or 7 hours to drive down to Boston. So, and in the winter, it's really challenging. So if you don't have access to radioligand therapy, and they definitely do not in the northern part of that state, or even actually maybe all of the state, then they're stuck. So I'm really happy that in various parts of New England, which is where I practice, there are more and more sites opening up to deliver radioligand therapy. But these are real challenges, and certainly I'm sure in areas where you live too. Texas is massive.
Yeah, and I think to your point, very interesting point. Once you have a dose of Pluvitco or something, you have to use it. There's a certain shelf life, and if a snowstorm happens in Maine and the patient can't come down there, he misses out on that dose, and you have to either find another patient or you just throw it away. So that's a big issue.
That's an issue for practices too, that have to kind of eat that dose.
Exactly.
Well, we're not going to throw it away or eat it. We're going to dispose of it in a very
in a
Please
good
don't
way.
eat.
Exactly.
All right. Okay.
That's not the message. It's never the answer.
I know. I'm kidding. All right, Chad. Here's one for you. How about sequencing lutetium and radium? I guess baked into that is one before the other and vice versa.
Well, I don't think anybody knows the correct answer to this because there's only that one alphabet trial that did the two together. It's an interesting question, and I don't know if there's a correct answer at this point. There needs to be bigger trials to really figure this out.
Yeah. There have been some smaller studies, really, with radium and then lutetium and even vice versa, that have shown, really good safety profiles in terms of, not detrimental effects on the bone marrow. generally speaking. I think that smaller studies and those have been helpful.
Yeah, but I don't think the answer of do you do the radium first, the lutetium, lutetium first, I don't think anybody quite knows that.
But from a safety perspective, it is nice. It's reassuring to see those trials.
Yeah. Okay.
Registries, I should say.
Do proton therapy candidates have the best prognosis versus other therapies?
Proton. Oh wow, we're going 9 degrees here.
Yeah, I got to use your expertise on the proton story.
Yeah. So proton therapy, it isn't quite indicated in patients with metastatic disease. It's more used in select patients with localized disease. But there's a lot of mixed data on proton therapy. I like to think of it as another tool. Like the surgeons have their really fancy robots. We have our fancy radiation machine. Yeah. So in certain instances, it can be helpful, but not all.
All right. How about, do radiopharmaceuticals work best within a particular age range?
Yeah, I think they're actually nicely accessible for all age ranges. I do make sure the marrow is sufficient. You want to make sure that the person has sufficient bone marrow, that they're not going to have pronounced cytopenias or that they're at high risk. You also want to make sure they have adequate organ function, kidney function, that kind of thing. But a healthy person who's an older adult should, I think, tolerate these drugs just the way that a younger person can.
But I do think it's important for us to recognize, look, there's a very low incidence of myelosuppression with radium. It's also relatively low with lutetium. You've got to monitor. Both require CBCs before each infusion. It's in the label. There are some different issues regarding actinium, as we saw in that warmth registry, the salivary gland issues. And I think these are things that we're learning a lot about and how to better baseline, understand salivary, normal salivary saliva production. And we're doing some studies, and you're probably both doing them too, and I'm learning how we measure that and how we measure changes, and then strategies to help patients for that as well. But
yeah. It's a good point, because right now all these studies it doesn't matter if you're 50 kilograms or 200 kilograms, you're in the same dose. And whether that makes sense, I don't know. Time will tell.
And actually, just to add one thing, not about salivary glands, but about older patients, one thing that I definitely talk to people about is what the home situation looks like. And for some older adults, they are actually the caregiver of their partner who needs a lot of care or support, or they themselves need a lot of care and support. And when you're giving an alpha particle, this may not be as big of an issue. When you're giving a beta particle, you need to sort of help them sort through that family situation so that they are not causing potential exposure to their partner or the other people in the house. And you can work through that with people, but that is sometimes a real thing to talk to people about.
Yeah, and there's good patient education, family caregiver education about things like that. And the populations, at risk for exposure, young infant children, pregnant women, et cetera. But it's very manageable. That's been my experience. So I think key take-home messages. By the way, any questions from the audience? Okay.
What do you think about the in-house mutation? The in-house mutation.
Like the home brew?
Yeah.
Like the INT. We don't do that in the U.S. as much. You mean like in Australia, Germany, South Africa? Yeah.
We are using not 6.7. We are using 10.1. 10.1.
Okay.
It's a little bit more safer for the renal function. I don't know, what do you think about it?
I think U.S. regulations don't allow so much for the in-house. Like Germany and Australia, they're really leading the way. That's why the warmth study in South Africa could be done there before we had really approval. So we're kind of learning from the rest of the world with these home brews.
Yeah, we don't have home brews. We have microbreweries for beer, but we don't have any home brews.
Yeah.
It's a good question. I mean, it's really interesting. I guess the quality control I'd be concerned about, but I don't know, maybe not.
It's cheaper for us.
Sure.
Yeah.
Very realistic. Okay. All right, we're going to go back to some of the questions to just ask again to see if we did any change in our answers. What was the effect of radium-223 and ENZA versus ENZA alone in PEACE 3? Significant improvement of both RPFS and OS, improvement in RPFS, not OS, improvement in the OS but not RPFS, no difference. I mean, the big take-home, too, in addition to everything we've talked about, I hope it's not an ARS question for you, is that how it's here to stay, the radiopharmaceutical world, on top of taxanes, on top of ARPIs, and on top of PARP inhibitors and immunotherapies as well. Okay, here's what we saw at the beginning. And
When is the beginning?
the one from the beginning is the...
Pre. Sorry, post, sorry.
The pre was the one on the left, right? No, yeah? Yeah, pre. Oh, the one on to the other. Okay. So, yeah, we obviously made marked improvement going to 71%.
Interpret it.
Yeah, okay.
Significant, yes.
That's a good result, right?
Yes.
You
Good,
heard Dr.
good.
Tang. Yeah. All right, you get to have dessert for that one. And now we'll go to the next one. What was the effect of lutetium-617 versus ARPI change, the sequencing, ABI to ENZA, ENZA to ABI, in PSMA4? Significant improvement in PFS and OS, significant improvement in PFS but no OS benefit, significantly improved OS but no PFS benefit, no difference between the two arms. Okay, well, we made improvement on it, right? We went from 21 to 40%. So I think I'm going to say not only does everybody get dessert, but a free glass of champagne.
Very good.
All right. So let me ask my colleagues, and maybe any of you, if you want to opine on it, the key takeaway from today. I mean, I'll say it. I think that, we were seeing here at ASCO GU, we had so many really interesting posters today in the session on both radium and lutetium, actinium, other really interesting molecules as well that Dr. Chang talked about. You've got, terbium, you got astatine, a lot of actinium studies. It's just a really exciting time in the world of radiopharmaceuticals. I think, to me, that's really one of the key takeaways and how we think about personalizing it better for our patients. But your thoughts?
Oh, sure, yeah. Well, I think we're seeing great strides as we're moving the treatments earlier and earlier. So I think it's going to be very interesting to see how, in 10 years, 5 years even, in what space we're using maybe localized prostate cancer, maybe, patients with biochemical recurrence.
Yeah. That's a great point. And there are trials on that.
Yeah, exactly.
And I love that you brought that up. So, yeah, in the BCR and in the high-risk localized, radiopharmaceuticals are certainly going to potentially have a significant play in that as well.
Yeah, I would say that I am so looking forward to us really adapting the treatments to our patients over time. So what I see is not just that we're using these different molecules and these different ligands, which are going to continue to expand. And so I think we're going to have a lot of exciting new tools to play with and to really help our patients. But we didn't talk today about the fact that sometimes people have extreme responses to these agents, which can be wonderful. And then should we pause and maybe restart if the cancer starts to grow again and have treatment-free intervals? And I think that we will find our way to something like that at some point in the future, really minimizing toxicity, personalizing around the cancer, about the patient, or around the patient as well, to find the right thing for them. And I also think, especially regarding this, moving into earlier disease, I think that these agents, and perhaps these agents in combination, do give us the opportunity to imagine a world where we don't have to use castration. And I think that is something that will also be amazing for our patients, and think this is going to be a vehicle to help get us there.
Yeah, love that point about could we be in a world one day where, T suppression is not always so reflexive. And then another really good point is this, we've talked about intensification, doublets, triplets, but then the de-intensification and the ability to safely interrupt, have drug holiday, and try to get back improvement in quality of life. So I love that. All right, here's an opportunity. I think we're kind of pushed up on time right now. We had great stuff from our virtual audience here. I thank them very much. If you want to send in a question, we may be able to type them back to you. But then also to earn your credits, scan that QR code. Always great to get some extra CME credit in addition to coming here to ASCO GU. Congratulations to all the organizers on that and all the folks who had abstracts and presentations. I don't really have much other than to say it was really great that you all are here. Thank the virtual audience. Thank this wonderful faculty. Hope everybody continues to contribute to these trials, because we do trials in order to change healthcare, don't we? Please stay with us. We've got another program to follow right here. It's gone MHSPC. It'll begin shortly. Our virtual attendees can also join through the link under resources. So you can get back-to-back CME and great education tonight. So great pleasure. Again, Chad and Alicia, thank you very much.
Thank you, everybody.